Welcome back, and this is our last segment for this seminar today. I want to introduce to you Ellery Russian. She is a physical therapist living and working in the Duwamish and Coast Salish area of Seattle. She's worked 15 years at the University of Washington Medical Center and specializes in neurological physical therapy and assisted technology. So Ellery, I will let you go ahead and present your slides. You could start your video.
Hi, can you hear me okay?
Yes, and I'm going to, there you go. You could go ahead and start sharing.
Yeah, so it's really great to be here. I wish I could see all of your faces. My name is Ellery Russian. I'm a physical therapist. I've been working as a physical therapist for 15 years. I'm on Duwamish and Coast Salish land in the city of Seattle, and I'm really glad to be here. Just a little bit about me and how, briefly, how I got into physical therapy and kind of my perspective on physical therapy is I was in a pretty major accident when I was 18, and since then I've had artificial legs. And so I've been through rehab and used a cane, crutches, wheelchair. I've gone through a lot of physical therapy myself and a lot of medical appointments and surgeries over the years. So I bring that personal perspective to my work, and I've always had a passion for wheelchairs and wheelchair seating because I think it's cool and interesting. And there's so assistive technology has become one of my specialties, and because of that, I've been really involved. I've seen a lot of clients. I see clients of all neurological diagnoses, but also we get a lot of folks from Children's Hospital that transition to where I work when they're about 20, 21. And I'm seeing a lot of folks there for physical therapy when they're transitioning out of pediatrics. And also I order a lot of wheelchairs for people of all, like simple wheelchairs, really basic, all the way up to like the most complicated. And I really am passionate about that work. And so through that, I have seen a lot of people with muscular dystrophy and cerebral palsy and spina bifida and some of those, diagnoses that come as a young person. And then also I've been really involved in ALS clinic. So I'm not really going to talk about ALS today, but I am going to talk just about neuromuscular disorders in general, and specifically and exercise. So it's only 20 minutes, but there is a lot of new and updated research, even in the last 5-6 years, on neuromuscular diagnoses and exercise. So I'm excited to kind of give you some of those updates. So I'll go into my slides now, but it's nice to virtually meet all of you. And feel free to email me after the talk is done. Okay, so the main thing that I want you all to come across with is that this is what is recommended in terms of exercise, that you get an early referral to physical therapy as early as you can, so that you know what all your tools are to help you be as strong and mobile as possible throughout your life. And if you were someone who went to physical therapy as a kid and really didn't enjoy it, and now you're an adult and you're having some chronic pain or your body is changing and you are thinking about revisiting it, I would just say, come back and we'll work with you specifically with where you're at and what your needs are. The other big things this talk is going to tell you is that exercise, for the most part, is recommended, and that it's really helpful, just as helpful as any medication you might take, any pills you might take. Be active, just be out there in the world, being active, move your body, but pace yourself, and be open to different forms of assistive technology. And I'll talk about all this more over these next 20 minutes. So, I'll be talking about how do you a lot of people want to know how to build strength, and they want me to test their strength and find out how strong they are. And what I've noticed is, and what the research says, is that if there is weakness, if there is muscle weakness, there's generally two reasons for having weak muscles. One is your diagnosis, disease, or disorder that you have that causes muscle weakness. But there's another kind of weakness, and that's just from not moving very much or not using the strength that you do have. And that's called being deconditioned or being out of shape. So the big moral of this talk, like I said, is that exercise in neuromuscular disorders is safe. And that's the biggest thing I want you to take away from. And I'll talk more about, there are parameters around that, but it is safe. And this is an important message because in the past, there was not as much research, and there's still not enough research, but it's improving. But in the past, doctors were very reluctant to prescribe exercise, and that's changing. So we want to keep up with the new information that we're getting and not rely on outdated information. So in general, what kind of exercise is recommended? So, and I'll talk about all this more in depth, but this is the key points. You want to be flexible, so you're in your joints and through your body. So stretching and range of motion should happen every day. Also working on your balance every day. And then in terms of strength training and aerobic exercise, I really can't get more specific than what I'm saying here, but at least 2 days a week for strength training and aerobic exercise. And anything more specific than that, you would just have to work with a physical therapist to figure that out, because a lot of that is based on where you're at in that moment in time, where your body is at in that moment in time, what your symptoms are at that moment in time, and kind of also what your diagnosis is, and where things are going. So we would work with you in person to tailor a program a little more detailed. So, but strength training and, so strength training is like training your muscle strength, and aerobic exercise is more like for your heart and lungs, where you get your heart rate up or you get your heart working. And that's more for stamina and endurance. So the research about strength training and neuromuscular disorders is what it says is that strength training can be really helpful for keeping the strength that you already have and slowing the process of muscles getting weaker, but it doesn't necessarily strengthen the muscles that have already become weakened from the disorder. So at the end, let me know if you have any questions about that, because we'll have time at the end of this for a Q&A. And, I talked earlier about that there are two kinds of weakness: a weakness that is from a disease that you have or a disorder, and a weakness that is from not using your muscles. And if you're working on strength training, a lot of it is also strengthening the muscles that have just become out of shape. So what the research says is that low or medium intensity strength training is good. Maybe, and this is very general, 10 to 15 repetitions can be beneficial for people who can fully, so if you can fully lift your arms and legs in the air all the way up, then you would be able to do this amount, and it would be recommended. But heavy strength training, or you may see the word eccentric, it looks like eccentric strength training, you want to avoid that. There's no proof that that is helpful. So I talked earlier about range of motion, and this one is a little bit tricky, but what it shows is, what this picture shows is, every joint in your body. So this is showing the shoulder. has a full range of motion. So lifting it all the way up in the air to the ceiling, lifting it, reaching behind your body, reaching out to the side, rotating your shoulder. Picture is showing the full range of motion of the shoulder. So if you are able to lift your arm, so some of exercise that we prescribe, first I just check what people's range of motion is in the clinic. I check their shoulders, their elbows, their wrists, their fingers, their neck, their back, their hips, their knees, ankles, and toes. And if someone has full range of motion in that body part, then we'll work on strength training in that full range of motion, and sometimes we can add weights. But if someone is not able to raise their arm all the way up against gravity, that means that the arm is heavy enough that it's already like a weight because the person can't even fully lift it. And so then we'll work on using the range of motion that you do have, but we may not give you weights. And for people who have a part of their body that has become weak to the point where they cannot move it at all on their own, then you need either to use your other side of your body, like your, let's say if your left leg, you just couldn't lift it at all. If you can kind of help with your hands or help with your other leg to move that leg through range of motion, that's great. But if you aren't able to do that, you would have a family member or a caregiver perform range of motion to that limb 10 times in a row every single day. I think one of the biggest things I see in clinic is when people have a body part that's become weak where they can't move it through the full range of motion. I find a lot of people aren't getting range of motion on a daily basis, and it is really important for the health of the joints and also for chronic pain management. So I'm going to say a few words about aerobic exercise. So aerobic exercise is what gets your heart rate up, and it's important for keeping heart health. A lot of people with chronic illness and disability have the additional issue of poor heart health, and some of that is just because they don't move very much. And so these are just very general guidelines because, again, it has to be specific for each person, but you can start with about 5 to 10. If you're not doing any aerobic exercise, you can start with about 5 to 10 minutes at a time and warm up gently before you do it. Stretch your muscles afterward to make sure you're staying limber. And I wouldn't do more than 2 days a week at first, because you want 2 to 3 days after you exercise to find out what effect that had on you. Sometimes you don't feel it in the moment, it's delayed. And then you could eventually work up to the goal of doing more than 2 days a week and at least 20 minutes at a time. But you wouldn't start there, you would start smaller and listen to your body and see how it responds before you know how much further you can go. A key thing is to ask yourself, how hard am I working between 0 to 10? And so I would say, because the research was encouraging folks to do more like no more than moderate exercise, I would say don't work harder than a 5 or 6 out of 10 on that scale. So that helps you gauge when you need to take a rest break. And a big thing is the talking test. You should be able to chat while you're exercising. If you're so winded you can't chat, that means you might be pushing it too hard. And you don't want to exercise yourself to the point that you can't then get up and do the rest of the things in your day that you need to do. So if exercise wipes you out for the rest of the day and you can't cook or do dishes or clean or drive to a medical appointment or, have dinner with your family, then you might be pushing it too hard with exercise, and we should pare back. So those are some general guidelines. So cycling is, so a couple forms of aerobic exercise. One is cycling. So going out with your family. This person in the middle is on a trike. So if you balance is too difficult for this 2-wheeled bike, you could do a trike that has 3 wheels and much less likely to tip over. And then this is also a trike. This is a recumbent hand cycle. So this person is riding the bike with their hands. So, you know, you can use legs, you can use hands, you can have a trike. There's a lot of different ways to do cycling. And then swimming is another recommended form of aerobic exercise. So whether you use a floaty or whether you are in the water with another person, all the way up to being able to do classes in groups of people. You know, one thing I would say, this is kind of the asterisk, you know, I would say about aerobic exercise is you want to check with a cardiologist first, because this type of exercise will affect your heart muscle. It's usually safe to exercise, but you just want to you want to see that heart specialist first, and especially for people who have these diagnoses, so Duchenne, muscular dystrophy, Becker, Emery-Dreifuss, myotonic dystrophies 1 and 2, and then different limb girdle muscular dystrophy types, and some other diagnoses. So just make sure that you do that before you jump into a cardio program. And when we make the program for you, we'll be looking at, you know, what is your diagnosis, and how is that expected to go for you over the long term. We want to know about where your heart and lung health is now, what your fatigue level is, pain, age. Have you exercised in the past? If not, then we'll be starting really fresh. If you have, then you have an idea of what exercise looks like, but if your body is changing, it might be different than what you used to do. We also look at, you know, is there any exercise equipment you have access to? And then this thing called kinesiophobia. So I wanted to talk about that. So what is kinesiophobia? It was kind of a new word for me, but I knew what the concept was. I just hadn't really heard the word. But kinesiophobia is fear of movement, activity, or exercise that happens when you're feeling vulnerable. And this is usually due to the fact that you've done exercise in the past and had a bad experience or had pain afterward. And so there's a lot of research about how when you have fear of exercise, it keeps you from exercising, and then that causes your energy level to go down because your cardiovascular, your heart and lungs aren't very strong. And so then it's sort of a cycle that keeps going. And so how do we break that cycle? So there's a lot of research about cognitive behavioral therapy and how that is really helpful in addition to exercise, or even sometimes instead of exercise. And so basically, cognitive behavioral therapy looks at how people think about their situation, like, how do I feel about exercise? And then you do cognitive behavioral therapy to learn to kind of change your thought patterns about something, so that you can be more constructive with it. And it asks you to distinguish between your thoughts and your feelings. So I feel, you know, so like, for example, I feel afraid to try the bike. You know, I'm really not sure how that's going to go. But then you can think, okay, maybe I'm letting my fear get in the way of me trying some things that could be helpful. And so you can use your thoughts to kind of question your fear, and help you maybe move through this cycle of being afraid of exercise and then feeling fatigued all the time and but feeling like you want to do something, but this happens a lot. And so it's not just getting you physically on board, it's also getting kind of mentally and emotionally on board with being able to exercise and figuring out what's going to work for you and for your body. So the big message is, you know, if exercise isn't your cup of tea, you know, if you don't really like exercising and doing exercises, the big thing is just stay active no matter what. You know, just do your best with being out there and trying to be physically moving your body. And you also want to be strategic. You know, if you accept where things are at, where your body is at, and you pace yourself and you listen to your body and use some tools like assistive technology that can really help you do your best in the long term. So looking at your calendar and thinking how many things you're doing in a day or over the course of a month, and trying to pace yourself with that so that you're taking breaks to let your body recover from doing too much. Also, stretch breaks are really key. You know, there's more research now that exercise groups like Outdoors for All or kind of community adaptive sports groups and exercise groups are recommended for people with neuromuscular diseases. So there's a National Center on Health, Physical Activity, and Disability, and you can go to their website. They'll show you what's in your region for community outdoor and sport groups you can get connected with. There's something called the Challenged Athletes Foundation. I don't love that name, but I think that they have a lot of connections nationally. At least here in the Seattle area, we have something called Outdoors for All. That's a great group. I've done a lot of wheelchair dance. So I put in, you know, if you're not an athlete, but you like to dance, that's a great way to move your body and get exercise. And I think if you want examples of people dancing, you know, with paralysis or with a wheelchair or with a walker, there's a lot of great YouTube videos out there, and it's awesome. So I'll just give a few shout outs to some assistive technology, and you can ask me more in the Q&A or we can discuss it more. You know, there's walkers, crutches, canes. All of them can be helpful. Sometimes, a lot of times when there's weakness in the ankles and someone's ankles kind of starts to collapse because of spasms or weakness, there are a lot of bracing options for the ankles. Kind of these ones on the bottom are more the modern version of that, and the one with the circle with the line through it is sort of like what the old-fashioned ones used to look like. They were very heavy and made out of leather and heavy metal and this kind of thing. And if that's what you think of when you think of a brace, know that the newer ones are made with really light materials like carbon fiber and things like that, and they've improved a lot over the years. And so you know, and just because you're using things like a brace or a walker or what have you, doesn't mean that you can't be active. You know, you can do both. So there's a bunch of different kind of manual wheelchairs and scooters. And this is something that if you haven't thought about it, you can add a little motor onto the back of a manual wheelchair and give it power assist. So it's sort of a hybrid between a power wheelchair and a manual wheelchair. This one, the motor is in the hub of the wheel. And then this one, this is an add-on piece. So the Freewheel with the smart drive is really cool. You know, power wheelchairs have also gotten a lot better over time, and they don't just get you places, they can also tilt you back. You can lie down, elevate your legs if you have swelling or pain in your legs. And for people who have a lot of weakness in the hands and it's just getting too fatiguing to drive anymore, you can drive with your chin, you can drive with your head. There is eye gaze operated drive, but it really only works indoors. And so we can talk about that more if you have questions about that, but there are a lot of options for if there's any part of your body you can move, including your eyes or just your lips, we can, you know, get you driving. And then just my last plug is thinking about how your body is positioned all day, because a lot of folks with neuromuscular disorders develop curvature of the spine and things like this from muscle weakness. And so just think about how your body is positioned all day long. And so in bed, when you're sitting, and if you're not standing, consider standing. So this shows someone who was lying in bed with their legs crossed, and then this shows them in a more neutral alignment with the pad between the knees, and that helps the bones develop well and the spine to develop more less of a curvature, which can be really helpful, as people age. There's a lot of benefits to standing, and these are a bunch of the different kinds of standing frames that there are now. And it's recommended to use one every day, basically. If you're not able to walk, if you've lost your ability to walk in the last 6 months, look into getting a standing frame. It's covered by insurance. And standing can also start at 9 to 10 months of age. So that was my talk. I have a bunch of references, and here's my email and phone number so you can get in touch with me.
Thank you, Ellery. That was a lot of information. Thank you so much.
Yeah.
We did get a couple questions, and I know that a couple of them were chatted in as well. Could you recommend right from the get-go, when someone is getting evaluated for a power chair, what are their certain demands that should be asked when you get a power wheelchair? This person just commented that he did not get an elevator function, and now he can't transfer on his own. Is there anything during the evaluation that should be stipulated by the therapist and or the patient from the get-go?
Yeah, that's such a great question. Some scooters and power wheelchairs have a seat elevate function, and the new ones, they lift you a full foot, so 12 inches. And most insurance does not cover that feature. They consider it a luxury, which you and I know that it helps you with transfers, it helps you stand up, and it's important. Labor and Industries will sometimes cover that, and sometimes some really nice private insurance. But I'm telling you this, and just this month, I have a client who has a spinal cord injury and is not able to transfer, needed the seat elevate for transfers. And so I asked for it. And this client has Medicaid, and they approved it. So I think the chances are low. It depends on what state you're in. I'm in Washington. But I think, you could ask your physical therapist or whoever to ask for the features that you want. And if the insurance company says no, so be it. It does cost between $1,500 to about $2,300 to add the standing feature to a power wheelchair. And so if your insurance denies it, you can pay out of pocket and add that feature. But, a lot of people will do a GoFundMe or a Kickstarter and have people donate for something like that. So it's something you could think about. It does make a really big difference in people's lives. But even if I write a very elaborate justification on all the reasons why somebody needs it, it's still sometimes the insurance company who just decides not to pay for it. But we'll push and try our very best, and sometimes they will pay for it.
All right. Pressure sores. I know that is a very big common amongst a lot of our families. Is there anything you could recommend to prevent pressure sores? I know the Roho cushion has been used. Sometimes they're not a fan of everyone. So do you have anything in particular you could advise?
Yeah. So when I talked at the end about the 24-hour positioning, that's a really big thing, because sometimes the sore isn't from bed. Sometimes it's from the bed. Sometimes it's from the wheelchair. Sometimes it's from the toilet or the shower chair. That's another reason why it's good to get a standing frame if you can, because it's a way to not be in bed and not be in your wheelchair. So when you're in a different position, you're getting pressure in different places. That can be good for skin. But I think the biggest thing is, if you're in bed, it's recommended to reposition at least every 2 hours. So you're not just lying in one position all night long, every 2 hours at least in bed. And then in a wheelchair, if you have that tilt and recline, like I showed in the slide, you could use that every 15 minutes to tilt back, at least every hour though, to tilt back. And if someone isn't, they really need to be, because that puts the weight in your back and not under your bottom. I don't know where you're asking about pressure sores. Some people get them on their heels and feet. But we look at the surface that's underneath the body. So like you talked about Roho cushion. They have the low air loss pressure relieving mattresses for a hospital bed. If that's something you haven't had in the past, it's something you could start to ask for now. And there are other options besides Roho cushions for the wheelchair. In the past, it used to be that was the gold standard, but there's a couple other really key options now that are really good for certain people. So I can talk to you more about that specifically if you want to email me, or we can be in touch.
Perfect, perfect. For someone who does not have any leg capability at all, any whatsoever strength in their legs, sorry, I lost my words. This person's wondering, how can you even stand at all?
Yeah, so I mean, there's a couple of things. One is they have braces that can brace you at the ankle and the knee and even come up to the hip. So you could wear braces to stand. Those can be really heavy and cumbersome. The standing frame, I'm going to go back a few slides and show a picture of this one I really like. I order these every day. So this doesn't really show it because of the way it was laid out, but basically you transfer into this as a seat, and then it cranks up into a standing, and it you strap the ankles, it blocks the knees, and then this blocks you at the chest. There's no way you can fall out of this. And then it brings you up so that you're basically standing just as straight as in this picture here, where she's standing up fully straight. And you can stand there for up to an hour every day. And so, and then also these are on wheels. So like you could wheel that into the kitchen and just be hanging out standing while your family's in the kitchen, or you could go to your window and be doing emails or eating dinner and standing while you're looking out the window. So you can set it up in an environment that you actually like. But I think that's a nice way for standing, because if you had braces on, it'd be hard to stand that way for an hour, but this the standing frame completely supports your body. So you can stand there for, an hour. I mean, if you haven't stood in a while, you might start at 10 to 20 minutes and gradually work up to an hour. But yeah, people check their email up there, when they're standing. They eat meals, they watch movies and TV, they read books, talk to friends and family on the phone. You can do upper body exercise while you're in the standing frame, depending on your abilities. So I think, anyway, that's my answer about that.
Okay, perfect. So I think just a caveat on that, he would definitely need to talk to his OT at his care center.
Yeah. So, and if they have questions, if they've never ordered a standing frame before, email me,
Okay.
because I just have a company bring in the standing frame.
Okay.
And then that's how that gets going.
Okay. One other question we got in is the barrier for patients to get insurance to cover their physical therapy, consistent, regular physical therapy, that is. So in between, can you recommend anything to get those muscles engaged while at home when you can't do in-person PT visits?
Yeah. So, I mean, I think the range of motion program is really key, doing range of motion. So this is abduction, this is flexion. And if you can't, so doing that 10 times each day, in each motion each day, and in your legs too, in all the joints, that can build strength. And I mean, I think when you do see a physical therapist, they should give you a program that you can do at home. Now with COVID, I'm doing a mix of in-person treatment and video treatment. And so I'll have people working out in their house, but I'm kind of coaching them from the video.
That's nice.
It's really awesome. And I've been doing that with people with different kind of spinal cord injuries and multiple sclerosis and some different things cerebral palsy, spina bifida,
Mhm.
where I kind of will coach you while you're at home. So that's actually now that insurance in theory is covering these video healthcare sessions, that's a nice way to kind of bridge that gap too.
That's definitely a great point. So I would recommend as well for this person to reach back out to their therapist and see if they could possibly do anything telehealth. Um, Perfect. Thank you. All right, Ellery, I don't see any other questions that came up. So thank you very much for your time and thanks for helping us on this Saturday.
Yeah, thank you. I'm really glad to have been here. Thank you very much.
Thank you. All right. Well, this concludes our seminar for today. Thank you all so much for joining us. I want to thank all our presenters for their time and effort that they put into putting in all their presentations. I think it was a plethora of information, and thank you so much for all your Q&As and your chats. I also want to thank once again our seminar supporters, Biogen, Numotion Foundation, and Genentech. We could not do this type of programming without them. And thank you for taking your Saturday to stay with us and learn a little bit today. We hope you found it informative and helpful. I know some of you might have questions after this, so please feel free to email to mdaengage@mdausa.org. And I know a lot of you got the email from that inbox, so you could just simply reply to that if you have any questions. We did record. And we will do a little bit of editing, and then we will put that up on mda.org in a few weeks. So check back for that. And also please remember, I am going to be sending everyone a brief survey. So if you could please take 5 or 10 minutes to fill out that questionnaire, we really appreciate it. And we look to your feedback to improve future programming. So thank you again for joining us, and we look forward to you joining other Engage programs. Have a great rest of your day.